Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good evening. I'm Dr. John Langell, and welcome to VITALS, Visionary Health Leadership in Action. This is designed to be an open and frank discussion about how we can come together to improve healthcare across this nation, especially using the tools associated with VITALS: value, innovation, technology, advocacy, leadership, and service. As part of this program, we bring in cutting-edge leaders who've had dramatic impact in improving healthcare and give them an opportunity to share what they've done and then engage in frank and open dialogue. And tonight, I'm incredibly pleased to be able to introduce Dr. Akram, the president and CEO of MetroHealth, Cleveland's public health system. Dr. Boutros has been an incredible leader in galvanizing the community, leaders, entrepreneurs, and others involved in the delivery of care to change the paradigm through which healthcare is delivered and improve it for all members of our community, especially the underserved. And today, we're going to have the opportunity to hear from him, learn from what he's done, and have a discussion around that. Dr. Boutros, the floor is yours.
Thank you, Dr. Langell. I really appreciate the opportunity to be here and to speak about this. So as you and I spoke, I think one of the things we wanted to cover is about good leadership. What makes what's the components of good leadership, and how do you get things done? And as I was thinking about it, it's a lot harder to talk about what excellent leadership is. It's easier to talk about what it's not. What things are missing from really intentioned individuals who want to lead organizations and the like. And for me, it boils down to really three things. So the first and foremost is that every organization, every leader needs to be focused on the mission of the organization. And that just, maybe trite to say, and a lot of people talk about that they're focused on the mission, but people need to be, as leaders, we need to be laser focused on what the mission is. And we need to be able to be focused on what it's not. We have to have very bright lines about what we are here to do and to serve. Anything else would cause mission creep. And mission creep is not an easy thing to guard against, because there are always good reasons to extend your mission. But it sends terrible signals to the folks who are supporting you, the people who are working in your organization, the people who are trying to carry out the mission day in and day out. It says that anything is possible. Anything can fall into our focus, and we can do good and then divert from our really intended purposes. I think once you are clear, once you know exactly what your mission is, once you have articulated what that mission is, you can actually use that as a litmus test for everything that goes on. And at MetroHealth, we actually use our mission, our vision, and most importantly, our values. And we look at through any initiative that anybody brings forth, even including things that are when we do our budget. When we do our budget, we look at our mission, vision, and values, and every new program that we're looking at, we measure it against those mission, vision, and values, and we prioritize them. And so it's easy for us to be responsive to people who are powerful, people who bring in a lot of money to the organization. So for a lot of healthcare systems, the neurosurgeon, the urologist, the orthopedic surgeon would ask for a tool, a piece of equipment that they want, and they would say, "This is what I need to be able to serve my patients," and they're pretty expensive. You have to weigh that against other things that you may be limited in budget to buy. And for us, we ask a simple question: is how many people is that going to serve? And if it's going to serve less number of people than an ophthalmoscope or a blood pressure machine or something else, then it gets a less of a grade than the one that's going to serve more people. And we also ask ourselves, is somebody else doing it? It is a gap. If the Cleveland Clinic is doing such a great job, and they are doing an unbelievable job in cardiovascular surgery and care, why is MetroHealth going to try to compete with them in that, when there are so many other areas in which no one is doing a really good job, right? So that's why that's what got us into the social determinants of health, right? Because not a lot of people were doing it. We saw the gap, and we wanted to be able to do that. So being laser focused on what your mission is, being articulating it clearly, having a set of values to it, and making sure you stick to it. Not, I've even challenged our board when they said they wanted to go in a different direction about certain things. I've said, unless you change the mission, that's not a good idea, right? So, and we've been presented with opportunities to make a lot of money that don't fit in the mission. So we say to ourselves, why are we doing it? We're not trying to create bottom line for the sake of creating bottom line, right? We want to accomplish something. And it's also one of the reasons why we went and borrowed $1 billion. Most of the organizations that we worked with, financial counselors and financial advisors, said to us, you're going to go from, by borrowing that amount of money, you're going to go from an A-rated credit to a triple B plus credit. That's 3 downgrades. And when I talked to the board, my presentation was, it's not relevant what our credit rating is, as long as we are serving our patients. If we can do more by having a downgraded credit, that's the right thing. And because we focused on our mission, our board went through the process, and at the end of the day, they agreed with management, and they said, we need to do that. So most importantly, when good people don't lead well, it is one of the underlying causes is because they're not laser focused on mission. The second thing, and this is a very human thing, and especially for people who move up in an organization, we get focused on ourselves. We want to know what our standing is within the corporation. That is, if I'm better than the next guy, I move up in the organization, and if I'm better than the other health system CEO, I have another job offer that can for a bigger health system and the like. So our standing, CEOs especially, really become often focused on their standing within the community, right? So they become focused on what decisions I make, how does that change my standing within the community? What is it? How does this change the standing of the hospital? So what that does is it really blows the risk of doing things that other people aren't doing. you're looking around, and unfortunately, kind of like lemmings, we are looking at what other people are doing, and we're following suit with it. And it's very hard sometimes to go against the grain, right? So for most of my life, I operated not-for-profit hospitals, and I was within the race of tertiary and quaternary care. Every health system I went to, I accelerated the amount of subspecialty care there is. When I came to MetroHealth, it was clear that University Hospitals like Cleveland Clinic were doing an excellent job with quaternary care and tertiary care. And what was missing was all the primary care and the comprehensive care and the preventive care and all of those things. Well, if I don't compete on tertiary care, what does that say for my standing? I'm not good enough. The health system is not good enough to do that. But I was presented with very large plan to build massive cancer centers on our grounds, and for me it was, look, it's okay. The care is being delivered by someone else, is being delivered effectively. That's all right, right? So I remember when COVID hit in March, and I remember reading all these organizations were furloughing people, were reducing salaries, were just hunkering down and saying we're not going to have any patients, so we need to be able to share the pain with our employees, right? People who work for us. And it would have been easy for MetroHealth to follow suit and say, that's the case, we're going to furlough people, we're going to reduce salaries, we're going to do all of those things. And as we discussed with our executive leadership team and our board, we said, look, if we want to fulfill our mission, our staff are really the most important asset that we have. To give them the message that when there are times are hard, we're not going to be there for them, we're only going to be there for them when times are good. It wasn't really the right approach. So we said, well, we really want to be able to give our frontline staff who were scheduled for a cost of living increase, we want to be able to carry through. That went against what everybody else was doing. And so we didn't want to take it out of the hospital's P&L. So we began thinking of how do we do that? And we went to our foundation, the MetroHealth Foundation, and said, look, we've never asked you for this before. You've usually given us money for research and other things. We think this is just as important. We think this is, as a critical moment, we need to be able to give money to our employees because their loved ones, their spouses, other people were losing jobs, and we needed them to continue to providing care for our patients. So we did not furlough anybody. We did not reduce anybody's pay. And the foundation approved it unanimously and gave us money to give people a 2.5% raise in the middle of the pandemic. And we did that in June, right? So sometimes this goes against the grain and people look at you and say, what a foolish thing. And for us, it wasn't about being foolish. We focused on our mission and what the right thing to do is. The last thing, so that this focus on where leaders stand in their decision making compared to other people, I think exaggerates the risk. The last thing is in healthcare, because most people who are in healthcare have grown up in it, right? So we've been medical doctors, we've been administrators, and we've been in healthcare all the time. And healthcare doesn't like to take risks, right? So I don't want you experimenting on me, right? So I don't want you, everybody else is supposed to get, there's a heart failure treatment that would help everyone in my situation. And you say, nah, I'm not gonna do that. I'm just gonna, shoot from the hip and try something, give you herbal tea and see if it helps your heart failure. Right, so we don't know how to manage risk. We, as leaders in healthcare, are often shy away from it. And the only way for you to be transformative, the only way for you to make leaps, right, to have this massive progress, is for you to take major risks. An understanding is that failure is temporary. Failure is not a permanent state. If you fail, you can learn something and you move on with it. So you know, for us, we've taken major risks. My first few months here, it was clear that MetroHealth was not paid appropriately by insurance company. So I showed up on June 1st, 2013. By October 1st, 2013, I sent a letter to every insurance company canceling the contract with MetroHealth. That didn't go over really well with them, right? But I said to the board, I said, look, there's no way for me to make ends meet here. There's no way for MetroHealth to be able to progress unless we are paid more fairly than we're being paid today. And sometimes we are paid 50 cents compared to the other health systems, right? That's taking a risk. Now, we planned for it. We tried to figure out how to mitigate for that risk, but we took that risk. And the board said to me, what's going to happen if this doesn't work? I said, you're going to fire me. I said, you're going to go and you're going to fire me and you're going to tell the insurance companies, you know, he was a little crazy and we're really sorry. And let's figure this out, right? And we did that. And within a couple of years, within 3 years, MetroHealth payment was much more in parity with other health systems in the Northeast Ohio. And it was the amount of fuel that we needed to begin our transformation. So we had to take a risk. We had to take a major risk. We thought about it. And I would say to you, there's a difference between careless leadership and fearless leadership. Careless leadership is just shooting from the hip and trying to you know, and hoping for the best. Fearless leadership is understanding what the risks are, thinking through how best to mitigate them, and still, despite the risks, doing the right thing. So, for me, in conclusion, I would just say there are 3 things that really sabotage excellent leaders. The first one is mission creep, not being laser focused on the mission. Second is being worried about one's own standing within the community, and whether the decisions they make will have others judge them. And the last thing is not taking enough risk in moving the organization forward. So that, for me, these are the 3 elements that people need to guard against.
Dr. Boutros, it's Monica. Thank you so much for your insight. Hey, we're going to open it up to questions. We've got about 31 participants. So if you have any questions for Dr. Boutros, please put them in the Q&A section and I will ask the questions that you come up with. Dr. Boutros, you and I go back far ways, you know, pretty much to when you came into the Cleveland area. And we were chatting. You think it's a failure if somebody has to go to the hospital. That's a thought that most doctors would not consider. Why do you think it's a failure if someone goes to the hospital?
So I would say to you, more people today would think that. But in 1992, when I went from chief resident to director of the medical service where I was doing my residency, which is in itself an interesting story because it was kind of like an experiment. Our chairman of the Department of Medicine took a chance on this young whippersnapper who had crazy ideas, and he literally took me from chief resident, where everyone was my teacher, and the next day on July 1st, all the division chiefs reported to me. So that felt very peculiar, right? But I didn't understand what a big risk that was and how he mitigated against it. So he was a good example of taking risks, right? He asked me to do the first grand rounds for the year, for the academic year. And then in July, I went up and I did this academic rounds, and he said, Akram, I want you to tell them what your view is of healthcare. So I had about 30 or 40 slides. On first slide, it had my name in as big letters as possible, and my title. On the second slide, it had these words: every admission to a hospital outside of trauma or childbirth is a failure of the healthcare system. Right? That's what I had on that slide. Well, I'm sure you can imagine is that it was in 1992. That was not. I didn't get an applause for that statement. As a matter of fact, I think within 30 minutes, the entire 200, 300 person auditorium vacated because they were yelling at me. Right? So the idea that we were responsible for everything that led to health to admissions to the hospital was not what at the time people thought doctors should worry about. For me, my patients, when I looked at my patients, I recognized that there were so many factors that impacted their healthcare. And one of the things I did not want to do was blame them. And we blame patients a great deal when we're providing care for them as physicians. We say things like they're a poor informant. We say things like they are non-compliant patients, right? We say they're non-compliant because they're not taking their medication. Never mind that they don't have money to buy the medication, they're non-compliant, right? As if they said, you know what, I'm not listening to you. I come here to you all the time, but I don't want to listen to you. That's just, that's not a great concept. So I thought to myself, there's got to be a better way than just prescribing medicine. We have to look at the overall issues of the patients. And that's what literally over the past 30 years led me to focus on social determinants of health.
Daniel has a great question for you. He wants to know, how has the current political environment impacted your role as a leader of a major hospital system? And he's looking for guidance in staying above the fray.
I tend to ignore it. I literally try to ignore politics. I try to ignore finance. I try to ignore these things because most of these things are temporary. I believe in a much better world. And I want to focus on our mission, right? I want to focus on what we do well. Honestly, it reminds, I tell people a lot of the time, and some people get mad at me. I worked for Catholic healthcare a great deal, right? And I worked for the Franciscan Missionaries of Mary, right? And they talked about the prayer of St. Francis, and they talked about the serenity prayer, right? Which is, give me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to tell the difference, right? To know the difference, right? That's what I honestly focus on. I can't change the political environment. I am just as a victim of it as everybody else. So I can't do that. I need to know about it. And I need to know how it's going to impact the organization, and I need to be able to focus on the things that I can change, and I focus on that. So I will tell you is that Republicans have been terrible to health systems from a reimbursement standpoint, equally has Democrats, right? In different ways, right? So we just have to adjust to whoever is making the rules and changes. So it doesn't matter to me. We're just going to keep doing what we do best, and that's how I think we progress.
Diane says Cuyahoga County has one of the worst infant mortality rates in the nation. Can you please discuss how MetroHealth is working to mitigate this situation?
I think we're going to be announcing some pretty good news for 2020. We had a significant reduction in infant mortality. It is the lowest in, I think, 30 years. We're going to be announcing the infant mortality. So MetroHealth and Cleveland Clinic and University Hospitals got together with the city and state and started First Year Cleveland. And we've been working at it for 5 years to do that. Patty DePompe, who is the head of the Rainbow's Children's Hospital, and I are co-chairs of First Year Cleveland. We got a lot of folks, agencies throughout the entire region working on it, and we've made some significant progress. What we've learned is that the major cause for mortality that we can manage is prematurity, significant prematurity. So we did some really good stuff with sleep, and that worked, but it's not enough. And now we're managing prematurity, and much to credit to the providers, they came together and they found out that the 3 health systems were doing things differently, and we were all counting for patients who showed up in the emergency room. We were counting on the other healthcare system to provide certain services. So we now have a unified approach to it, so they can make sure that baby comes to term. Babies who are below 22 weeks of gestation have a greater than a 90% chance of death. So we need to focus on that.
Amy wants to know, she says, thank you for leading the major hospital system in the area that is the safety net for the underserved. How have you been able to address the challenges of COVID-19 in looking out, especially for the underserved communities?
Well, so this goes to the mission of MetroHealth again, where we look for gaps, right, where other people are not providing care. So we went to homeless shelters. We go to group homes for disabled patients. What we do is we seek where there are significant gaps. So we did a lot of testing there. The jail population, I mean, we really managed that incredibly well. And but you know, there's a lot of coverage, but we went down to 0 COVID positive patients. That number over November and December went up to 200 positive COVID patients and 400 people in quarantine. We predicted it. We knew it was going to happen. We worked very hard on it. And it's now down to about 30 or 40 people are COVID positive and only 30 people under quarantine, right? So and I'll say it again, not a single patient was admitted to the hospital for serious COVID illness, and we have not had a single death out of COVID, out of a jail that has about 50, 100 people at a time. So like I said, we focus on where care isn't being delivered, and we do that.
Stephen wants to know, how would you advise medical pharmacy and graduate students in training to best prepare to become leaders in their field?
So I'm going to tell you what I tell my daughters, right? There's often we are asked to go do beyond our job, right? We do extra work, take on a project that is risky, do something. For all of us who are older, and not including you, Monica, other people, I hope you remember the Life commercial when the Life cereal commercial, when nobody would try the Life cereal commercial, and they would, and the older brothers said, "Give it to Mikey, he'll try it," right? I tell people all the time, where no one wants to go, you should go. Because you will learn something from it, you will grow, and it will give you opportunities to do more. So like social determinants of health, when we began that work, nobody was interested in it. People were like, "What are you talking about? That's up to the government. That's up to social work agency. That's up to not-for-profit agency. This is not medical care. That's not health care." And we said, well, we think we should figure it out. And if we're wrong, we're wrong. And if we're not, we're going to learn a great deal from it. So I say wherever you see a challenge and everybody walks away, raise your hand and say, "I'll take care of it. I'll do it."
Daniel Daniel says, MetroHealth recently received a multi-million-dollar gift from the Glick family. Can you please explain what that gift is, just for those who may not be aware? But he wants to know, what's the secret and what was your role as the leader in the process?
So we received, the Glick family committed to a $42 million gift to MetroHealth. And the story goes like this. We literally, we met the Glicks 2.5 years ago. They were interested in looking for supporting some endeavors associated with healthcare. We started with a very small project, and we started talking to them. Joanne is a nurse. She understands healthcare very well. And every time she came to MetroHealth to look at the project that they were supporting, which was called SAFE, which is where students are free to express. It helps students who are in high school and elementary school who are under significant stress be able to discuss their issues and gain some support from their teachers and their fellow classmates, right? So she saw that as very different. Bob is a businessman. Bob Glick is a businessman, and he is full of questions. He doesn't take the answer you give him at face value. He constantly asks you questions. And Bob is constantly probing. So you tell him something and he goes on and on. He became unbelievably interested in our approach. And I joke around with him and I said, Bob, I should have charged you $1 a question and I would have gotten more money, right? Than $42 million. Because he asked lots and lots of questions. My role and my team's role was not to get the money. Our role was to continue to focus on what we're doing and answer the question. If the money came, that's great. We'd love it. It's the right thing to do. And if the money didn't come, well, so be it. We meet some friends, we answer their questions. They understand us better. So I would speak to Bob every month or every 2 months, but we have a couple, my entire team was really open to it. Bob and Joanne wanted to know about our CFO. They wanted to know how am I as a leader. They wanted to know how am I really in the community. They wanted to understand our finances. They wanted to understand how our medical staff works together. And we said, go ahead, go have a discussion with them. But the people who really made this happen is Kate Brown, who is our president of our foundation, and Brian O'Neill, who is the chairman of the board of our foundation. They called me when they needed me to talk to the Glick family and answer questions. But at the end of the day, it wasn't, we didn't have a driving force of getting the money. If it came, it came. If it didn't come, it's okay.
Brian has several questions. Brian wants, first of all, he says, great presentation. And he wants to know, can you please speak to your position on reshoring or insourcing? And are we doing enough right now to mitigate COVID?
So there are, one of the things I spoke to the governor about, and I'm trying to make happen with Ohio Hospital Association and Jobs Ohio, is production of PPE in Ohio. I want us to be able to not be reliant on other countries to have the proper equipment for us to take care of our community, right? So and for me, I've spoken to my colleagues, the other CEOs of the healthcare systems, and I said, we're being penny wise and pound foolish. We're looking for a reduction in costs and putting that on the bottom line, and just for the year. I said, but if we gave jobs to every Ohioan who's out of employment today, our finances would be better. We'd have better communities. People would have enough money to be able to spend. They would be able to buy health insurance. In the long run, it is in our best interest and national security for us to be producing PPE here in America, and Ohio should be the leader of that. So I don't think we're doing enough. I think we need to do more of that. And we need to be able to support one another to make it happen and focus on the long-term return and not focus on the short-term benefit.
Are we doing enough to mitigate COVID? And what are your suggestions for enhancing local community position in addressing COVID and planning for recovery?
We're going to, MetroHealth has been immunizing really quickly. I think a lot of the other healthcare systems in the region have gotten their processes very well tuned, and now are also doing that. There are some boards of health that are working through this process, and I think it's going to get better. I think vaccinating people is going to be the most critical aspect for us to getting back to a normal pace and having the economics, the psychosocial support. We as human beings are not made for Zoom. I mean, we're not made to spend 24 hours a day without human contact. It is not helpful. It has long-term negative impacts. Is it a cool technology? Yes. Should we be able to use it? Absolutely. But we need to get back together and be able to hug one another, see our parents, see our grandparents, go out to dinner. I mean, Monica, that's how Monica and I honestly started to develop a more of a relationship, is that we went out to dinner, right? You took me, you introduced me to Sarita, right? The restaurant, right? So, which is, by the way, I go to this really, really nice restaurant and all that. So that's what we're made for as human beings, right? We're made for contact. And so we need to be able to all get vaccinated and be able to get back to seeing each other as individuals, coming across each other, having discussions, instead of having this finite point in time in which I see you for Zoom for 30 minutes, we're done, and we move on to the next thing.
You and I did another event a while back talking about how the local hospital systems need to be anchors in the community, and they need to step up when needed. We're in the middle of a pandemic. It's a health issue. One of the things we're seeing right now is this vaccine rollout is so incredibly slow. If you were in charge, what would you have done differently? And what do you think we can do now to change the situation we're in?
I honestly, I would go through the phases a lot quicker, and I would not say that you need to finish 1A to do 1B or to do 1C. I would say we're going to give you a finite period of time in which that you can be in the front of the line, and then we're going to open it fairly quickly to the next phase of people. If you're reluctant, it's okay. It's fine. We want to be able to get this vaccine as quickly as possible. What I'm absolutely appalled at is that there's been vaccine wasted. You hear about it in New York and other things. I'm just utterly appalled at it. My dad is 97. My mom is 94. They cannot wait. I mean, they're constantly asking me, when do you think we can get the vaccine? And I tell them, I'm not, I don't live in Virginia. You got to figure out with your doctor and healthcare system where you're going to be able to get that. But it seems like we want to be meticulous in how we deliver it instead of universal in how we deliver it. Excuse me.
Have you shared those thoughts with the governor, and has he listened?
I have not spoken to him about it. I've shared it with the OHA. I will tell you is that our governor is really doing his best. You can criticize decisions on all of that. He's a good human being who is trying his utmost to do the right thing for the community. He doesn't want us to be in this situation a day longer. And that, to me, you can't ask for better leadership than somebody who wants to do the right things for the right reason.
Roderick wants to know, how can we better use data and evidence-based medical decisions to care for the underserved when trust of physicians is a barrier? And that goes along with the vaccine as well.
Yeah, so I will tell you what we have found out is that all these surveys and everything else doesn't apply to your personal relationship with your own physician. So again, this idea of contact, right? So there's this dichotomy of asking people, do you trust doctors? Do you trust, how do you feel that physicians are responsive to your to care in general? And what you will find out is that if I'm talking about if I'm talking about your doctors, not my doctors, but your doctors, if I'm talking about in generalities, we don't trust them as much as we do. When you ask me, do I trust my doctor? We go from a 60% to a 90% trust ratio. So there's this whole idea that your doctor is not trustworthy, but my doctor is, right? So it goes to this personal relationships. And all you have to do is spend 5 minutes with a patient, not talking about their health, but talking about their current situation, their family, and everything else. And you establish trust very quickly.
Fayez wants to know, you did mention enhancing research at Metro. Can you provide us with more info and how you use innovation and research for healthcare delivery?
We have an entire division, which is the Population Health Innovation Research Institute, that looks at implementation sciences, which is where we're not doing basic science research. We're not doing clinical research. We're taking the tools we have today and figuring out how do you combine them to get a better result, right? To get better outcomes. We have Dr. Sherry Boland, who leads that research, and we do a great deal of it at MetroHealth, and we're investing millions of dollars more a year to expand that, about $3 million a year.
I want to open it up to more questions. If you have any for Dr. Boutros, please just put them in the Q&A section. While I have you, we witnessed a very difficult year in 2020, and one of the highlights of that, race relations and racial inequity, and what we're seeing, especially relating to healthcare. I know Metro has a number of programs specifically targeting these issues. Can you touch on those, and where have you come from, and where are you going in relation to those programs, especially when you have the new hospital being built?
Yeah, so there are two ways to look at health disparities. One is, what things are you doing that are different for different races, right? So if you are a patient who has diabetes and you're white, are you being offered the same number of services? Are you as a African American or a Latino, right? So one of them is not outcomes. It's actually, are we providing you the same services? As I think you covered multiple times, Monica, women don't get the same level of attention for cardiac disease, right? So the first thing we need to do is actually just deliver the care irrespective of your ethnicity, right? And over the past 10 years working with Better Health Partnership, I can say, very proudly, Cuyahoga County, for diabetes care, for immunization, for a lot of different things, we now can say everybody is being offered the same care, whether you're Black, you're white, or you're Latino, right? So that doesn't mean we have the same outcomes. So the next thing now we need to do is figure out what are the unique differences between individuals so that they can get the same outcomes. And that's one of the things we're looking at, for example, in first year Cleveland. Toxic stress that is as African American women are are experiencing is creating significant prematurity, right? So if we're going to solve for prematurity, I can't treat a white woman and a black woman the same because they're not experiencing the same issue. They're genetically equivalent, but they're not experiencing the same life experiences. So we have to know what the difference is between them. So we have to figure out what things we can do to support them so that they're not feeling this stress. So for example, MetroHealth is opened up a home for women who are pregnant, who have an opioid addiction and want to be able to have healthy babies, and also typically have a structure in which they may have come from a violent home or have had abuse and the like. We give them a protective area so that they and their babies can have very positive outcomes, right? So we're trying now, we're delving in housing of these women during very high risk periods of their lives.
We're seeing, I'm not seeing any more questions. If anyone has any, please put them in the Q&A. But you know, if we're not going to get any, I have one final question. There is, you know, aside from the fact that the pandemic kind of derailed all of our plans, you know, we entered into a new decade. What are you anticipating to see relating to healthcare delivery and how it may change in the next 10 years? And already we've already seen, because of COVID, we've already seen technology changing. We know we're going to be using telehealth. We know, you know, medical devices are just going to improve and they're going to be more hands-on, like my Fitbit. But from healthcare delivery, where do you see the future? Because that's really imperative for medical students to kind of have an idea of what they may be getting into.
So I will tell you is the history books will not look at, I do not believe the history books will look at the COVID pandemic as an ultimately negative point in our history. I think they will look at it as a painful but positive inflection for how we deliver care. So I wish it didn't happen. I wish so many people didn't get sick. I wish so many people didn't die from it. But I think what it caused us to do is to think, get out of our comfort zone and do things that we've never done before. We had an idea at MetroHealth to do hospital care at home, and I've been talking about it for 3 years. We didn't have a single patient. We now are averaging about 30 patients a day that are in a hospital at home program in which we're providing equivalent care. It is, I can tell you in my lifetime, we're going to have ICU care at home in which you will have a nurse by the bedside providing ICU care around the clock. That is unbelievable. That is much better than being in a hospital. It's much better care, less, significantly more cost effective. And talk about not being isolated from your family and having everyone around you so that you can get better and do more. It's going to be amazing. So I think it was the wake-up call that we needed to embrace change, to think about the social issues of healthcare. You know, 2020 wasn't only the year of COVID. It was the year of recognition that there's significant racial inequity in our country, and now healthcare organizations that have said in the past, this is not our thing, are now making sure that they're doing the right thing for racial equity and inclusion. So I'm very positive about the future, and I think it's going to be a great progress for healthcare and for our community and our country.
Dr. Boutros, as always, thank you so much. Dr. Langell, I'm going to hand it back over to you.
Thank you, Monica. Dr. Boutros, thank you for that incredible discussion, for sharing your leadership philosophy and the approach that MetroHealth takes to transforming healthcare, especially its focus on the social determinants of health for the patients that you care for. Monica, thank you for your expert moderation once again. And I ask all of you to please join us next month when we'll hear from Dr. Toyin Ajayyi, the co-founder and chief health officer at City Block Health, as she'll lead us through a discussion on leading healthcare change through service and advocacy for our communities. Until then, stay well and stay engaged. We are the source through which healthcare transformation will occur. Have a wonderful evening.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.